Hello, I'm Parul Tandon, a gastroenterology resident at the University of Toronto. I would like to welcome you to our inflammatory bowel disease educational video series sponsored by educational grants from the Canadian Association of Gastroenterology and AbbVie Canada. These videos were developed to target critical issues in IBD that are routinely encountered in inpatient and outpatient care. Recent published evidence suggests that Canadian gastroenterology trainees are not fully satisfied with the level of IBD exposure under the current training model, and several topics appear to be inadequately covered during training. As such, our aim is to provide a comprehensive update on core and complex inflammatory bowel disease topics to improve trainee knowledge and overall confidence levels. We plan to do this by interviewing Canadian inflammatory bowel disease experts in an engaging and interactive format. The target audience for this program includes gastroenterology trainees and early career physicians managing patients with inflammatory bowel disease. This program is an accredited self-assessment program under Section 3 as defined by the Maintenance of Certification Program of the Royal College of Physicians and Surgeons of Canada and approved by the Canadian Association of Gastroenterology. Each module is approved for 2 hours of Section 3 credits for a total of 6 credits for all trainee modules. Please remember, the accreditation expires March 15, 2022. The Mount Sinai Hospital and University of Toronto Division of Gastroenterology allow for the posting of the program for educational purposes only. The information, dialogue, and included slides are presented by faculty specifically selected and recognized as national experts in the field. The content of this program is to be used for educational purposes only, and the participants of each video assume no liability for the information herein. This is video 3 of the series. This video will discuss the ever so complicated topic of nutritional assessments and recommendations in inflammatory bowel disease. Though nutrition is such a critical aspect of our daily encounters with patients, it is often overlooked. In fact, a recent survey through the Crohn's and Colitis Foundation of America demonstrated only 41.1% of gastroenterologists reported a very good knowledge in nutrition and IBD, and only 48.9% perceived nutrition to be very important in the overall IBD care. This is concerning because we know malnutrition is quite common in patients with IBD and can manifest in a variety of ways. Furthermore, it can be associated with worse disease outcomes, complications, reduced quality of life, and increased mortality. As such, we will try to summarize an approach to the nutritional assessment of the patient with IBD with a specific focus on reviewing current fad diets available for these patients. Specifically, the objectives of this video will be to understand the main determinants of malnutrition in IBD, to recognize common micronutrient and vitamin deficiencies in IBD patients, to use appropriate tools for assessment of malnutrition in IBD, to appropriately manage patients with malnutrition in IBD, and to recognize available diets and their evidence for use in these patients. Our expert joining us is Dr. Talia Zenlea. Dr. Zenlea is a gastroenterologist at the Women's College Hospital in Toronto, Ontario, with a particular interest in inflammatory bowel disease. Dr. Zenlea completed subspecialty training in gastroenterology at Harvard University Beth Israel Medical Center, where she also had a clinical focus in inflammatory bowel diseases. Thereafter, she joined the faculty at Brown University as an assistant professor of medicine at the Alpert Medical School and acted as a director of the Inflammatory Bowel Diseases Center at the Women's Medicine Collaborative. Here in Toronto, she also serves as the associate program director of the Gastroenterology Training Program at the University of Toronto and an assistant professor of medicine at the University of Toronto. Dr. Zenlea, thank you for joining us today and taking time out of your busy schedule to teach our viewers on nutritional assessments in inflammatory bowel disease.
Thanks for having me.
So let's get started. Nutrition is such a complex field, and it's often difficult for us trainees to understand and get a solid understanding of how to manage nutrition and malnutrition, particularly in the IBD patient. So maybe you could introduce our viewers to that field, define malnutrition, and why it's so important to think about.
Sure. So nutrition is important for any chronic disease, but particularly in the patients with IBD because of some of their unique disease characteristics. So I think we need to understand what that means so that we can properly screen our patients. So malnutrition can really be any deficit in either protein, calories, or any other micro or macronutrients. We often think of a protein-calorie malnutrition or undernutrition, and we usually see that in patients who have lost weight or who have a low BMI. But it's important to recognize that even in the absence of weight loss or a low BMI, patients can have deficiencies in some of those nutritional variables. So it's important to recognize them and be able to screen for them.
So, particularly in the IBD patient, why is nutrition so important to consider in our daily practice?
So patients with IBD are at particularly high risk of malnutrition or undernutrition. Statistics as high as 60 or 75% in terms of this patient population. So it's been recommended that we screen all of our patients at the time of diagnosis and then periodically throughout our care for them at least once a year, if not more. So why is it important? Because we've shown that malnutrition or undernutrition can adversely affect the disease course, particularly in patients who have active disease or who are flaring, but even those who aren't. So in the active disease population, we've seen that they're at higher risk of hospitalization, of longer hospital stays, even of things that seem unrelated, like blood clots or PE. So these factors are really important to recognize because they can really change how we modify the course of our chronically ill patients as we care for them.
I agree, that holds true for all other chronic diseases as well. So before we move on to how to manage nutrition and malnutrition in patients with IBD, I think it's important to understand the pathophysiological mechanisms in order to understand what approach to take with these patients. So could you briefly discuss sort of the different pathophysiological mechanisms behind malnutrition in these patients?
Yes, for sure. So I do think it's really important to understand the pathophysiology of malnutrition. It can be quite complex. So there are a variety of different reasons behind malnutrition in IBD, including decreased oral intake, inflammation and malabsorption, GI nutrient loss, and negative drug-nutrient interactions. Perhaps one of the more important and critical factors resulting in malnutrition in IBD is decreased oral intake, and arguably the biggest culprits behind this are us as physicians and healthcare providers. When these patients are unwell and hospitalized, they're often kept NPO for procedures or placed on restrictive diets for specific indications, for example, a low residue diet if they have stricturing disease. This can contribute to caloric loss and can progress to overt malnutrition. In addition, because of GI symptoms like nausea, vomiting, abdominal pain, patients will often forgo certain foods or macronutrients, like carbohydrates, which in the setting of inflammation can result in malnutrition. Finally, in recent years, there's been some lay press suggesting that as many as 70% of IBD patients use elimination diets to try to manage their symptoms or disease. Other mechanisms that can result in malnutrition include malabsorption, either from inflammation or from previous surgeries, and then altered micronutrient absorption and utilization from steroids or other immunosuppressives. So it can get pretty complex. I think the take-home message is that it's important to do a comprehensive multidisciplinary assessment.
So why don't we use that as a transition to discuss how to actually assess for malnutrition in these patients. So could you briefly discuss for our viewers of the different tools available to them to help diagnose malnutrition?
Sure. So we can start with just a good history and physical exam. So asking the patient, are they restricting any types of foods? Is there any reason why they're not eating the way they should because of symptoms, pain, or whatever? And are they adhering to any restricted diets for any reason? We should always ask about weight loss. And then you can use other tools like the Subjective Global Assessment, or the SGA, which really goes into more detail of how to assess patients. I think the important take-home message, though, is that A, we should be doing it, and once we're doing some sort of initial screen and identified patients who either are losing weight or restricting food or calories for whatever reason, that we then work together with our nutritionist and dietitian to do a more comprehensive and thorough assessment that will gather more specific information as to whether they're malnourished or not.
So I feel that in our daily practice, especially in a busy residency program, we often resort to using albumin and BMI as a surrogate marker for malnutrition. What are your thoughts on that?
So I think those are great surrogate markers, but it's important to understand that they have limitations and that the most important thing is a more global and holistic assessment of the patient. That said, the BMI can be really useful, particularly in patients who are underweight or who are actively losing weight. So if you've determined that their BMI is dropping, then that's definitely a red flag. The caveat to remember is that just because somebody has a normal BMI, or even if they're overweight, it doesn't mean that their nutritional status is adequate. So not to be falsely reassured by a normal or elevated BMI. Same thing kind of goes for the albumin, particularly in sick patients. So we know that albumin is a negative phase reactant, and in ill IBD patients, we know it's going to go down. So again, that doesn't mean they're malnourished. And the flip side is once you start to replete some of those nutrient losses while they're in the hospital, you're not going to see the albumin go up right away, and that's okay. So they're great surrogate markers, understanding that they have caveats and that we have to look at the big picture.
So let's briefly discuss micronutrient surveillance and recommendations from the recent European guidelines. Could you briefly review those for our viewers?
Sure. So I think the important thing to take home from the European societal guidelines are that every IBD patient should be screened, whether they're well or whether they're flaring, hospitalized, and sick. So we often ignore this in the patients who are doing well because we think, okay, they're eating, they're treated, and there's no reason why they would be malnourished. So important to recognize that those patients warrant screening as well. The other thing to take home is that the patients who are ill and in the hospital, a lot of the markers that we follow, the micronutrients, are going to be falsely elevated or decreased because they're acute phase reactants. So just important to remember that those need to be sort of interpreted cautiously before we draw conclusions. And again, it gets back to what we were saying before, that it really comes down to sort of a holistic and multidisciplinary approach and assessment.
So let's talk about specific micronutrient deficiencies, and let's start with the most common deficiency, iron. Could you go over the algorithm to when to check for iron deficiency and how to manage it when found?
Sure. So the European societal guidelines would suggest that we should be screening all of our IBD patients at least annually, and probably more frequently if they're active. So for the patients with active disease, every 3 months is probably appropriate to check both hemoglobin as well as iron indices. Then it becomes a matter of repleting them. So for the patients who are doing well, they're not having active GI symptoms or active disease, and they've previously not had any intolerance to oral iron, then it's probably appropriate to replete them orally. But for the patients with very active disease or who have low hemoglobin under 100, IV iron is more appropriate as an initial starting point.
So moving forward from iron, could you briefly discuss the various vitamin deficiencies that may be present in IBD patients and how to manage those?
Sure. So I think the 3 big ones are vitamin D, vitamin B12, and folate. There's no specific guidelines as far as how often to be checking these, so annually or at the discretion of the treating provider. So for vitamin B12, because it's usually due to terminal ileal disease, obviously think of it more in patients with Crohn's disease, especially those with active TI disease, but it's probably not unreasonable to periodically check in any IBD patient, and it's quite easy to replete. Again, if they have active TI disease, probably intramuscular repletion makes more sense, and for everybody else, oral repletion would be appropriate. So other B vitamins, folate, we should also check for that. And then also important is vitamin D, particularly since we know that the IBD patients are having IBD alone is an independent risk factor for osteoporosis. So we don't want to compound that risk by having them also be vitamin D deficient and then repleting it as appropriate. And then some of the other ones are more subtle, so we don't always have symptoms from deficiencies in like zinc or magnesium. So again, at the discretion of the treating provider, but probably annually. Alternatively, we could also put these patients on a multivitamin, which is probably adequate to replete some of those deficiencies.
So I think you made very important points in that early recognition of these micronutrient deficiencies will eventually lead to hopefully improved outcomes and prevention of other diseases like osteoporosis. Let's shift gears a little bit and let's talk about the inevitable question that all gastroenterologists get, and that's the link between diet and inflammatory bowel disease. What are your initial thoughts on that?
So my initial thought is that that's a really important topic because patients always want to know about this, whether they're sick or whether they're well. The one thing they can control is what they eat, and they always want to know which diet is the best for IBD. And the answer is we don't really know. So we lack randomized control trial data to really give us a clear answer to that question, but there are a lot of diets discussed in the popular press that make claims to improve IBD. So I think it's important to have a general understanding of what some of those are, as well as some of the data that exists surrounding them.
So then why don't we talk about the specific diets that are available, particularly the more popular diets?
Sure, so there are numerous diets that have purported to improve IBD. Most of them focus on restricting carbohydrates, and that's probably because of the effect of carbohydrate intake on gut microbiome and intestinal permeability, as well as in driving some of the symptoms like abdominal pain and bloating. So let's talk about some of the specific diets. So let's start with the specific carbohydrate diet. This was actually first described in 1924 to treat celiac disease, but the data for this diet in IBD is very limited, mostly just case reports. but it's highly popular amongst patients because there was a book called Breaking the Vicious Cycle that claimed that it treated IBD. So this diet only allows for the consumption of monosaccharides and simple carbohydrates. It's a strict grain-free, sugar-free, and complex carb-free diet. It permits intake of lactose-free yogurt, fresh fruit, meat, eggs, and fish. It can result in significant amounts of weight loss because of its elimination nature. So caution is really needed to monitor these patients' nutritional status and weight carefully if they embark on this diet. So the next diet is the FODMAP diet, which is well known to all of us because we use it in IBS. So the FODMAPs are highly fermentable, poorly absorbed carbohydrates and polyols that can result in increased intestinal permeability, which can in turn be a pathophysiologic mechanism that drives IBD. So the FODMAPs comprise of fructose, lactose, fructo and galacto-oligosaccharides and polyols like sorbitol and mannitol. There's no prospective data on this particular diet in IBD, but retrospective observational studies suggest that a low FODMAP diet may be an excellent strategy to manage functional symptoms that may also be present in patients with IBD. So symptoms like abdominal pain, bloating, diarrhea, these can be improved with this diet. There's also the ketogenic diet, which is low in carbohydrates and high in fat. This is similar to the specific carbohydrate diet. Its aim is to induce ketosis, which can result in a lot of weight loss and prevent fermentation of carbohydrates by colonic bacteria by limiting access to these key nutrients. Another possible diet is the gluten-free diet. We know, of course, of this in patients with celiac disease, but it can also reduce abdominal symptoms like pain, bloating, and diarrhea in patients who don't have celiac. There was a study done by the CCFA Partners cohort that they looked at over 1,500 patients who reported a reduction in abdominal symptoms in about 65% of them on a gluten-free diet, with a third of these reporting a reduction in the severity of their flares. However, there's no link to reduced inflammation. Then there's the anti-inflammatory diet, which is proposed to combat the altered GI microbiome that can play a critical role in disease pathogenesis. This diet also limits the intake of particular carbohydrates, specifically lactose, refined and processed carbs, and can promote the intake of probiotic foods and decreases the total and saturated fat intake. Then there's a lactose-free diet, which is suitable for those with lactose malabsorption, resulting in abdominal bloating and diarrhea. Lactose intolerance is reported in up to 70% of patients with IBD, so careful elimination of lactose may really benefit them. The effect of this on inflammation again remains unclear. Other diets propose a high quantity of meat and fat. In other words, they're low in fruits and vegetables. These can include a semi-vegetarian diet, which was studied in a small prospective trial of 22 patients from Japan. The diet was lacto-ovo-vegetarian, meaning eggs and milk were allowed. They could have small portions of meat every 2 weeks and fish weekly. This trial showed significant prevention of disease relapse and high rates of clinical remission. However, it was very small, and as such, the results should be taken with caution. Finally, there's the Mediterranean diet. We all know that harmful fats can result in increased gut inflammation, possibly resulting in IBD flares. The Mediterranean diet is rich in fiber, olive oil, low-fat dairy, poultry, and eggs. This diet is associated with improvements in health status and inflammatory markers in colitis, and there are several ongoing clinical trials that determine the precise role of this diet in IBD.
Wow, that can be quite overwhelming, and that was an excellent summary, so thank you for that. Are there any particular diets that are currently recommended in inflammatory bowel disease patients?
The first that comes to mind is the pediatric population with flaring Crohn's disease. So there's pretty good data to support the use of polymeric enteral nutrition to induce mucosal healing even, and can be comparable to steroids and anti-TNFs. So that's one population in which we would use that. The data for adults has not been as robust, but certainly in children. The second unique population is patients with high output stomas. So these patients might need parenteral nutrition to keep up with their fluid losses and other micronutrients. And then the last is active flaring Crohn's disease patients and the use of low fiber diets. So I get asked about this a lot for all IBD patients, and there's no data to support its use for patients with ulcerative colitis or patients with quiescent Crohn's disease. But in the setting of an acute Crohn's flare, low fiber diets can be beneficial.
So when is parenteral nutrition recommended in these patients, and what's your experience with that?
So that's a good question. And now that we're developing safer parenteral nutrition formulas, I think we're going to get asked this more and more. So we need to have a better understanding of when to use TPN. So the European guidelines summarizes these indications quite well, and we'll talk about that in a minute. But I think it's sort of a big picture assessment of the patient, and it really comes down to, can they eat? Is there a reason why we don't want to feed them? Is it urgent? And what's our end point? Is this a bridge to something else, a bridge to surgery? Where are we going and why are we doing it? So the main indications for TPN in IBD patients would include oral or tube feeding not being possible because the GI tract is dysfunctional, short bowel syndrome where oral nutrition has failed to meet their nutritional needs, an obstructed patient, post-surgical complications such as an anastomotic leak or high output fistula, and then complex non-perianal fistulizing disease with an abscess or a phlegmon. So people often wonder if all enterocutaneous or even all fistulas require TPN, and the answer is probably not. It really depends on how high output the fistula is, where it's located, and whether there's a reason why you need the patient to have bowel rest, such as to get them to surgery or to promote healing. So for example, for more distal fistulas, like involving the terminal ileum or colon, as long as they're low output, those patients are probably okay to eat as long as they can do so. But for more proximal fistulas or for high output fistulas, or in patients with phlegmons or reasons why you want them to heal quickly, those patients probably need some TPN.
That was an excellent summary on the indication for parenteral nutrition in inflammatory bowel disease. Well, Dr. Zenlea, that was a great summary. We've talked a lot about how to diagnose malnutrition, how to recognize it, how to recognize various micronutrient deficiencies, and I think the most interesting part was to talk about the different popular diets available for our patients. Any parting words for our viewers today?
I think the most important take-home message is just to assess our patients for their nutritional status and to remember that it's a multidisciplinary approach where we're going to work carefully with our dietitians both for assessment and for treatment.
Well said. Thank you for joining us.
Thank you for having me.